I am an intensivist. I work in one of the hospital environments where there is mostly technology and high-tech treatments. That's how people usually think about intensive care. But intensive care units are mainly about people. The relationship between all these people in the ICU are so important. The dynamics of the team, but more importantly, the relationship that we build with the patient and the family.
Sono rimasto particolarmente colpito dal pronto intervento ogni volta che avevo necessità, sia a livello fisico che psicologico. Il personale interveniva sempre con molta affabilità, quindi molto gentilmente. Mi sentivo veramente accudito e protetto in ogni momento della giornata. Quindi da questo punto di vista sono rimasto molto soddisfatto. Venivo inoltre informato su quegli aspetti clinici che avrei dovuto subire da quel momento in poi, quindi mi veniva spiegato nei dettagli cosa avrebbero fatto e come lo avrebbero fatto. Al momento del risveglio non avevo ovviamente le idee molto chiare, stavo vivendo due realtà diverse, una quella vera in rianimazione e un'altra che era quella degli incubi, per cui il primo periodo non avevo ancora capito bene quale delle due era vera. Solamente dopo aver parlato ripetutamente con i medici che mi rassicuravano e mi spiegavano appunto questo fenomeno degli incubi e soprattutto anche dopo aver parlato con mia moglie al telefono, ho capito qual era la vera realtà. Le due realtà erano vissute ambedue dentro il reparto, quindi per me era difficile distinguere. L'ingresso di mia moglie in terapia intensiva è stata una inaspettata e piacevole sorpresa. Non ricordo molto di quel momento, le parole soprattutto, però ricordo benissimo le sensazioni e lo sguardo di mia moglie. La terapia intensiva è un'esperienza sicuramente molto dura e viene vissuta probabilmente in modo diverso da ognuno di noi in base al proprio carattere. Il messaggio che posso mandare è un messaggio di fiducia e di speranza, in quanto dobbiamo totalmente metterci nelle mani del personale sanitario che ha la formazione corretta per gestire soprattutto gli aspetti, oltre che quelli clinici, anche gli aspetti emotivi della persona e quelli psicologici, che sono, secondo me, forse per il paziente e la famiglia, gli aspetti più importanti.
You are the spouse, you are the brother, the sister, the parents, the children of an ICU patient, you are a friend. All of you are family members. Of course, we are not going to have the same communication with any of you according to what's the relationship between you and the patient, but we are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
The team was so human and kind. They helped me psychologically every day. I was waiting for the call every day with impatient. So that period was really very hard for my family. The team of ICU became really my family. I felt them closer even than my parents. Every day someone from the team called me and informed me about the situation of my husband and the next steps to do. And I want to say that even if I was far from my husband, I have been always updated about his clinical situation. And when there were very important decisions to make, for example, like tracheostomy, they called me 5 times per day. So I want to say thank you. For me, it was a new experience, like for many other people. I have never faced ICU. So after this experience, I changed my life. I changed all points of view. It was a really very hard period, and I was about to lose my husband, but I have never lost hope, and I tried to be strong and rational. I remember my first visit in ICU very well, because it's impossible to forget. It was so emotional. After 64 days, finally, I could see my husband, touch his hands, see his eyes. It was really very difficult to live without him and without personal contact. I don't have enough words to say Thank you to the doctors for that possibility that they permitted me to visit him in ICU. Thank you very much. I'd like to say to the future patients and their families that they should trust to the staff of ICU. They're allowed in the hands of professionals that work tirelessly with passion and love. They are always with the patients. The patients are the primary focus for them. They always gave the warm care and necessary treatment. They never leave alone patients. They are always with them and ready to help them in any moment. The patients are the primary focus for the staff. At the end, I want to say, no matter how ill is the patient, don't give up hope.
Having a loved one in the ICU can be an extremely distressing experience. Some family members suffer from symptoms of anxiety, of depression, some feel lost or even disorientated. So don't forget to take care of yourself. Sometimes you will need to take a break. You don't have to stay with the patient 24 hours a day, and you mustn't feel guilty if you do need to take that break. Don't forget that the ICU team will continue to care for the patient while you're not there, and they will always call you if there is a change in his or her condition.
My name is Silvia. I'm a critical care nurse. I work in an intensive care unit. My work is to assist the doctor and to help them to prepare the patient to get all the medicines and the treatments they need in the ICU. When the family first enters in the intensive care unit, I will receive them and welcome them and present them the room and the patient and explain the condition of the relative. I will be there to receive also their emotions, how they are feeling about it, and explain them what the patient is feeling at the moment, what we are going to give them for treatment. We will be there in any case to help them to go through these days in the intensive care unit and to perceive and communicate with the patient. We will be there to help him and assist him to the toilet, to the feeding, and to do anything that the patient will not be able to do. But moreover, we also will be there to see how is he feeling, if it's uncomfortable, if it's in pain, to learn to communicate with him all over the stay with all the equipment he will have. We will explain them the things that will happen to him and to his family, and to interact between the doctors and the patient.
The main role of a physiotherapist is the rehabilitation of the patient. With the term rehabilitation, we mean restore the previous situation that the patient had before his or her injury, his or her trauma. And so the patient could have again his or her previously autonomy in the best way it could be possible. A physiotherapist could work inside the intensive care unit, so it is a member of ICU team for all his or her working time, while in other countries the physiotherapist comes to ICU just only for the rehabilitation moment.
Hello, my name is Stefan Schaller. I'm an anesthesiologist and intensivist. As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients. My role is to coordinate the healthcare team to do the diagnosis and the treatment of the patient. To you, as a family members, I have to explain what is going on with your family member in the ICU. I explain to you what we are doing for diagnosis. I tell you the options for treatment and how to treat the patient. Very often, we have to discuss what are the wishes of your relatives, although he's not responsive. Therefore, we discuss together with you what is the best care we could provide for your relative. In the beginning of your ICU treatment, very commonly you are unresponsive. You will be examined by me or a colleague every day. We will make the diagnosis plan and the treatment plan. Later on, when you're waking up again, we are starting to talk with you about the treatment plan as well. While you're unresponsive, we try to discuss the care with your family, or we look at any documentation you provided, how the care should be provided for you.
As a social worker, I'm part of the ICU team. I regularly come on a daily basis to the ICU and talk with the professionals on issues with the families or with the patient. For example, when it's about communication or when there are conflicts, but also when the families have a request so that I can help them to overcome that issue. What I notice is that the families have a really difficult time. They are stressed about their loved one, but they also have, for example, issues for themselves. For example, they have questions, can I take my children into the ICU? Or how can I manage the homework? Or what can I do about financial problems? So I try to help them with that kind of issues. And sometimes they are also asking life questions, because, for example, why is this happening to me or to us? And what's the meaning of this, that he or she is going to have this critical illness? So I try to help them with this kind of issues. My relationship with the patient is to get him or her to learn him better. And I think it's very important to have the values, what is important for the patient, to have them bring into the care that we provide in the ICU. And I think that it is compassionate care, humanizing care, and that is combined with the highest technical and medical treatment that we provide. And in that way, we have excellent care that we can provide in the ICU. And I try to bring my expertise and to have the patient and his meanings and his opinions in front of it.
A special aspect in my daily practice is the communication with the patient and the communication with the families. Communication in ICU is very difficult because clinical situation is very complex and sometimes it's not so easy to explain to families. And in my opinion, the most important thing is to try to keep it very simple, not to spend a lot of technical words, but I just only try to explain the clinical status with simple words. It's very important to try to develop a relationship with the patient and try to keep it quiet, to tell him that the situation is under control. It's very important to maintain a patient calm and confident with the team, because very often the patients are very scared by the environment of the ICU. So it's very, very important to guarantee the comfort of the patient.
We work together as a single team with patients and families, and that's crucial for the recovery of our ICU patients.
Good morning, good afternoon, and good evening, dear colleagues and friends. I'm Mervyn Moore, and it's an absolute pleasure to be able to be with you this afternoon. And I'd like to extend a hearty and very warm welcome to everyone who's joined us this afternoon for this Management in Trauma Injuries webinar, the first of two such webinars. I think it would be pertinent to just discuss a little bit of the background. All of us have been through a very arduous 2.5 years with the COVID-19 pandemic, but we face an epidemic in many regions of the world, related to trauma, particularly in low and middle income countries and in conflict and war zones. And I think it's absolutely imperative that every intensive care specialist has a sound and a principled knowledge of trauma elements as they pertain to intensive care. Today's webinar, in fact, will focus on several of these aspects and include a unique and novel practical laboratory demonstration on a human cadaver. This is the first time, to our knowledge, that we are aware that any such educational webinar within this field, from an educational perspective, is taking place, and we're really greatly indebted to everyone who's involved. We, in fact, will also be using special technology so that the audience can view exactly what the surgeon is seeing. In other words, the surgeon's eyes will be shared with viewers on this particular webinar. And so it really moves me into the next aspect, which is a real delight to introduce the faculty for today. And we really have a wonderful trauma faculty that is of excellent international repute. Professor Steve MOENG, who currently is caught up, but hopefully will join us in a while. That's the nature of trauma. He's currently the academic head of trauma at the University of the Witwatersrand in Johannesburg, an internationally respected trauma surgeon and trauma critical care specialist. He is involved in multiple international societies, local societies, and is instrumental in the rollout of many courses related to trauma, including the ATLS course and the DSTC, the Definitive Surgical Trauma course, around. Really excellent trauma surgeon, and we're really thrilled, and I hope that he will be able to join us. Additionally, we have Dr. Marissa Hubert, who works in the same institution. She's also not only a trauma surgeon, but a trauma critical care specialist with extensive experience, also involved in many of the aspects that have been alluded to already, works in the same institution as Professor MOENG, as well as at Mill Park Hospital, where there's a very large level 1 trauma center. And additionally, she has been a trauma team leader in various war zones, including in areas such as Mali. She's passionate about trauma education. And then the final trauma surgeon we have in today's webinar is Dr. Rian Pretorius, who's currently the academic head of trauma surgery at Chris Hani Baragwanath Hospital, which is one of the 3 largest hospitals in the world, 3,400 beds, a massive volume of acute care patients and a very significant trauma load. And in fact, just for the viewers who are listening to this, the size of that hospital is 70 hectares in size. It's an absolutely massive hospital. And many of the world's leading trauma surgeons and people in other surgical domains have actually cut their teeth in this particular domain and developed their skills with what people are exposed to there. On an everyday basis, there's massive trauma, including major gunshot injuries and across the spectrum of trauma. So we really have 3 wonderful trauma experts who will be with us today. And then it's an absolute delight and pleasure to introduce my friend, colleague, and great collaborator, Dr. Martin Dunser, who joins us from Linz in Austria. Martin is an emergency care physician, an intensive care specialist, and has been involved in trauma extensively, including under the umbrella of the ESICM, where just pre-COVID, Martin, if I'm not mistaken, you in fact arranged one of the major trauma satellite meetings that ESICM hosted. Martin really has a spectrum of information and excellence that always surprises me, and it's a delight to have him join us today. I'd also like to say a huge and a very big thank you to the amazing ESICM education team. Today, Intella Condi is leading the team, but to Melania Estrata, Elisa Vieira, Estelle Pasteur, thank you so much. It's just such a wonderful pleasure and privilege to work with you. Again, to the excellent expert faculty, to the brilliant audio-visual team, to the ESICM exec, Professor Mauricio Ciccone, Professor Elia Zule, and Mr. Joel Alexandra for their ongoing immense and wonderful support at all times. And to all the members of ESICM who've joined today, to members of the Global Intensive Care Group who've helped facilitate and share suggestions for these webinars, and to all those who've taken time out to join us today. And then a final thank you to Mr. Lawrence van der Walt from Rods and Cones, who's in fact supplying us with the technology today that will hopefully allow you to be the surgeon's eyes as we are taken through these practical procedures. In terms of the sequence of events, we're going to commence with 3 talks. We're going to cover an approach to neck trauma, an approach to chest trauma, and an approach to cardiac injuries. We're then going to move into the Cadaver Skills Laboratory. And this is one of the few cadaver skills laboratories located anywhere in the world. An absolutely world-class facility. And we're going to go through a number of relevant and practical procedures that are pertinent for the intensivist to have a very good knowledge of. We're going to address things like cricothyroidotomies, tracheostomies, intercostal drain insertions, and emergency room thoracotomies. And thereafter, we will in fact take questions. And please feel free at any point in time to pose questions in the chat. These will be looked at and answered either at the time or subsequently during a Q&A time at the end of the practical procedures, where there will also be interactive discussion with the various faculty members. And so really, it really is an absolute delight, and I can't wait for us to get started with this webinar. A very gracious and a humble thank you to everyone. And I think we're going to kick off proceedings and ask Marissa to take us through an approach to chest trauma.
Thank you very much, Professor Moore, for your kind introduction. So I thank you very much for also having me on this forum. I appreciate the opportunity. I'm going to be discussing thoracic trauma, which I have to admit is an entity that in South Africa we see a vast number of cases, both blunt and penetrating. Penetrating, there's quite a bit of interpersonal violence in our country, so we do see a lot of the penetrating chest injuries. And then in terms of blunt, as part of our multiply injured patients, the vast majority do have a chest injury in a greater or lesser degree. The most commonly seen chest injuries are colloquially called the deadly dozen, which are then further subdivided into the 6 immediate threats to life and the 6 potential threats to life. Due to time constraints, I'm just going to be focusing on the immediate threats to life and how we can manage and diagnose these quite expeditiously in order to save lives. So the first one that we quite commonly see is a tension pneumothorax. So what happens in this situation is that there's a massive air leak from an injured lung, and this acts as a sort of a one-way valve. So the air enters the pleural space but cannot exit, and that leads to lung collapse. But the big issues start once the mediastinum starts shifting to the opposite side, when the great vessels then kink, leading to decreased venous return to the heart and eventual cardiovascular collapse. So on the right-hand side of the screen, you can see an X-ray. Please note that an X-ray like this should actually not exist, because this is in actual fact a clinical diagnosis and should preferably not be picked up on an X-ray. It should already have been managed by the time an X-ray is taken. So these patients often present with significant air hunger, They, if they can still speak, they literally tell you that they can't breathe. They have absent breath sounds on the affected side, hyperresonance to percussion, which is sometimes a bit difficult to elicit if you're in a very busy, very noisy emergency room. Tracheal deviation is also present in some of the cases, but it's not a definitive sign. If it's not present, it does not mean that the diagnosis cannot be there. And these patients are also generally quite hypotensive due to the decreased venous return. Treatment is actually quite simple. This needs to be decompressed quickly. It can either be done through a needle thoracocentesis. In the past, we used to say in the second intercostal space midclavicular line, but this has been noted to actually not be as efficient as doing it in the same space that you would insert an intercostal drain. So in the fifth intercostal space in the anterior axillary line. The reason for that is the fact that the chest wall is much thinner in that area, so it's much easier to do a needle decompression. You can also do a finger thoracostomy. So basically that is the same incision you would make for an intercostal drain, and then just inserting your finger into the pleural space. And once you to stretch the hole open, once you take that out, then there's a massive gush of air to decompress. And please note, this always needs to be followed up with an intercostal drain. The second condition that we're going to look at is an open pneumothorax. So these are also commonly called sucking or blowing chest wounds. So for normal ventilation to take place, you need negative intrathoracic pressure. With a very large open chest wall defect, there's an equilibration of the intrathoracic and atmospheric pressure. And if this hole is sizable enough, the air will actually enter into the chest cavity directly into the pleural space and not into the lungs through the airway. And that then creates massive ventilatory issues. The way to deal with this is that you need to seal this defect. The easiest way to do it is to place a transparent plastic over it and seal that on 3 sides with tape. Sometimes it's a little bit difficult due to the fact that these patients often have a lot of blood on their chests. So just wipe the blood off well and then put the dressing on. Place an intercostal drain away from the side of the wound, and then this wound needs to be definitively repaired, which can be done very often under local anesthetic just by extending the skin wound a bit and then closing the underlying muscle defect in layers. You can also place, if you don't have something quickly available to make a 3-sided seal, you can just place a normal dressing over this wound. Please then note that you have to place an ICD very quickly, because you can turn this open pneumothorax into a tension pneumothorax if you don't quickly decompress. Massive hemothoraces, also quite commonly seen, defined as the accumulation of more than 1,500 milliliters of blood in the chest cavity. These patients present with symptoms and signs of hypovolemia. They also have absent breath sounds on the affected side, as with a tension pneumo, but on percussion, that side of the chest will be dull due to the blood that's in the chest. So something that I think has definitely made a big difference in the lives of trauma surgeons, especially in resource-limited settings where we don't have a large volume of banked blood immediately available, is the use of autotransfusion. So after insertion of the intercostal drain, we have specialized chest drain sets called Sinapi. It's a South African brand, but there are also international brands available, one of them being the Atrium. So what that does is then you collect the blood from the pleural cavity, and provided that there's no contamination of that blood, you can give it straight back to the patient by connecting an infusion set into the chest drain bottle. You can also even use a normal underwater chest drain to autotransfuse blood. Please just bear in mind that if you put any fluid into the underwater drain bottle, it has to be saline and not sterile water, otherwise the blood will hemolyze. and you also need to add 1,000 units of heparin. If the patient continues draining blood or remains unstable, you will need to go and perform surgery to try and stop the bleeding, but please only if the expertise are available, because bleeding in the chest can be very challenging to control. And if not, then just giving the patient blood until they can get to a definite site for definitive surgery is your best bet. Flail chests, also relatively common. So that's defined as 3 or more ribs, contiguous ribs that are broken in 2 or more places. The flail segment itself is not really the biggest issue in these patients, but what leads to the mortality is actually the very large underlying lung contusion. Paradoxical chest movement can be noted of these patients, and what that means is on inspiration, the flail segment will actually be sucked in, and on expiration, the flail segment will be blown out. You can also get flail segments involving the sternum if there's sternal fractures and associated rib fractures. In terms of treatment, you actually really need to manage the lung contusions, and you need to make sure that the patient is ventilating adequately. So first and foremost is adequate analgesia. Generally, we start with opioid analgesia, but some very useful things that actually tend to work better if you have the expertise and the facilities available is if you give these patients epidural analgesia at the thoracic level. That works really well. And we also have catheters now that give continuous intercostal nerve blocks that also appear to be quite promising. You can start with supplemental oxygen, but please keep a close eye on these patients because a lot of them do require ventilation. And something that has made quite a bit of a resurgence recently is rib fracture fixation. And there are quite a number of studies that have come out showing improved outcomes in terms of fewer days on ventilation in patients with flail chests who have their fractures fixed. It's unfortunately at this stage quite an expensive endeavor and not freely available everywhere. Cardiac tamponade, something we especially see in our penetrating trauma, so any type of penetrating injury within what we call the cardiac box, which is defined as anywhere from your clavicle up to the xiphisternum, from up to down, and on the sides up to the level of the midclavicular line. The classic Beck's triad that's described of distended neck veins, hypotension, and muffled heart sounds are actually only present in about 30% of patients, so should not be relied on as a diagnostic modality. Fortunately, with the advent of bedside ultrasounds, we can actually quite easily diagnose these just with a simple bedside ultrasound. Surgery is the definitive treatment to manage this because in your penetrating injuries, you do know that there's something inside the pericardial sac that is injured and you need to stop the bleeding from whichever structure it is in order to stop blood accumulating. Pericardiocentesis very rarely done. It may buy you a bit of time if the patient is far away from a surgical center, but the big issue is the number of iatrogenic injuries because centers that don't have the surgical capability to manage this will very likely also not have the expertise to do proper ultrasound-guided pericardiocentesis, and doing it blindly can lead to a lot of iatrogenic cardiac injuries, and you can even have, if the positioning is incorrect, you can also have iatrogenic liver injuries, which we have seen. So, in conclusion, there are quite a number of life-threatening conditions that you can diagnose quite easily clinically and by bedside tests. And most of these can be treated by the evaluating doctor. So just by placing an adequate drain or by decompressing, you can save big number of lives, and there's very rarely a need for emergency thoracotomy in these patients.
Thank you very much, Marissa. That was a wonderful, pragmatic, practical overview of elements and some of the new nuances that have come through. And I'm sure that everyone who listened to this almost certainly has learned something new just in this 10-minute overview. So I think absolutely fantastic. I think what we will do is move directly into the next talk and hold any questions for our Q&A interactive discussion. And so it gives me great pleasure to introduce Dr. Rian Pretorius. Rian, once again, thank you very much for joining us today. As mentioned, Rian runs the trauma unit, one of the world's 3 biggest hospitals, and they see anything and everything on any single day. But today, Rian is going to address us on an approach to cardiac injuries, which almost certainly today in your institution, Rian, there will probably be several of.
Thank you very much, Prof. Yes, so I'm going to talk about cardiac injuries. As trauma surgeons, we are quite pathological people. You know, we're adrenaline junkies. So when we get woke up 2 o'clock in the morning and it's a stab heart, we are all excited. As big as Baragwanath Hospital is, we don't have any cardiology on or cardiothoracics on site. So we do these as beating hearts. So I'm going to talk about, sorry, I'm just trying to get my slide moved. First, this is one of my first cases when I started off as like in a private practice. And they flew me a patient with basically, it was an interaction that would quite have been a good discussion about the patient who a heavy duty vehicle drove over his chest. And that was his vitals at that stage. He is 60 years old, his blood pressure 68/40, SAT was 78%, heavy smoker, multiple refractions with cardiac and pulmonary contusions. So this gentleman, we actually ended up not being able to scan him initially, and we admitted him straight into the ICU and give him supportive management. And took us another 2 or 3 days to actually be able to scan this patient. Then we've got another patient admitted. If you look at his chest, this paradoxal movement of his chest after he was involved in the MBA also. So you can see that there's massive chest trauma involved with this patient also that actually made it very difficult for us to actually manage this patient initially. So he was basically multiple rib fractures, and he's got then bilateral rib fractures and bilateral pneumothoraces. So the lesson I've learned through the years is involve as many specialities as possible. It sounds like a cop-out argument, but you can see his blood pressure was 180/40. Me as a trauma surgeon think, must I cut something? Must I not cut something? I got an intensivist involved, and intensivist says, like, there's a problem here. Let's get the echo. Obviously, we can't do a transthoracic echo. We had to do a transesophageal echo. And he had complete aortic valve disruption. And that explains why there was such a big discrepancy between his systolic and diastolic. So we're not knowing, call a friend. That's the moral of the story. I think that we need to know what it is. And a lot of these can come from multiple things. From blunt trauma, we've seen a lot of blunt trauma. Blunt cardiac injuries ranges from 8 to 71%. 20% of all MVC deaths are attributed to cardiac injuries. And we've seen a lot of, especially right atrium disruptions from blunt trauma. Even from, we've had actually the two boys are fighting, and the one boy kicks his brother in his chest, and he ended up having a arrived hemodynamically unstable. And then on the FAST, you find that he actually had a tamponade, and he had a right atrium. So don't think that you cannot have chamber disruption because of blunt trauma. We actually do see it quite a bit. So there can be MVCs, falls, crush, assaults, sports-related injuries. We all know the famous headbutt in the soccer game. So we need to be very careful about, like, when we review these patients. And I think the difficulty in picking it up is that they are very non-specific. You know, blunt trauma can be very silent, transient arrhythmias. You can get myocardial infarctions. You can get myocardial wall ruptures, or you can, more commonly, I think we can actually get valve injuries because the tinea has then been disrupted. It's just a different part of it. I'm not going to go through the different grades of it because there's lots of grades that we can actually look at to see what is the grade of it. Because I think with cardiac injuries, especially with blunt cardiac injuries, you have to treat the patient symptomatically. So you actually have to look at the patient and treat the patient, and not necessarily like, but you can get from minor ECG abnormalities to complete heart blocks, to valve disruption, to actually cardiac wall disruption. So obviously, if you have a complete avulsion of the heart, your chance of survival is next to zero. So how do we diagnose it? So we're going to have to use the chest X-ray. On the chest X-ray, we often look at the cardiac index and see if we can see the aortic knuckle. We see if we can look at the size of the heart. And you see sometimes the right side of the pericardium is completely a straight line. So it's not as if it is like the normal shape it is. We do ECGs, we do Holter ECGs, cardiac enzymes. You can do serial cardiac enzymes, and then you have to do either transesophageal or transthoracic echo. So just as approach to these patients, hemodynamically unstable patients, if you excluded the tamponade, you can admit them to ICU and give them organ support. If they're stable, what we do is we do drop these ECGs abnormal, then we do serial ECGs and do cardiac monitor and eventually echo. Mild injuries, we can just do the ECGs and then might actually be able to discharge them. So the management, 90% of the blunt trauma will be supportive management. Almost most of the ones that's penetrating will end up in surgery. Then we have to think about Ecma, and then surgery is the next port of call. So when we think about Ecma, I would like to remind you of the two types of Ecma. We get vena-vena Ecma and vena-arterial Ecma. So vena-vena Ecma is used for patients who've got pulmonary dysfunction. So that's more for pulmonary support. Vena-arterial, we use it for patients who've got inability to have adequate cardiac output. So then you can use vena-arterial Ecma because it actually supports the heart and help you to actually pump oxygenated blood through the body. So as Dr. Hubert reflected on about the Beck stride, we often talk about the hypertension. We look at it stabs medial to the midclavicular lines. We look at the distended neck veins. But as he said, that 30% of them are actually show the signs of the Beck stride. And the reason for it is because sometimes they actually decompress. So they either bled out, so they can't have distended neck veins, or they actually decompress into the pleural space. So you don't have that compressive effect on the heart that actually causes you to have the distended neck veins. This is a classic thing that we often see in Baragwanath Hospital. As Prof said, we probably do 3 or 4 stab hearts a week. That's mainly what we do a week. And here is the typical case at Baragwanath Hospital how they present. A bradycardia, hypertensive, and when we do the bedside sonar, you can see the amount of fluid around the heart. So, and that will immediately show to you that this patient needs to go to theatre immediately. We look at the X-ray, and as I said, with the X-ray, you sometimes see a bigger cardiac shadow, but more prominently is actually described as the heart's shape becomes a straight line on the left side that you actually need to look at. We talked about pericardial windows also. So if in doubt, unfortunately, we live in a country with a high TB rate, and pericardial effusions are quite common. It's to determine whether it's a pathological pericardial effusion or not. So what we do is we go sternum and then basically stay extraperitoneal and then open the pericardium. If there's blood inside of it, then we do go straight and do a sternotomy on this patient. And if not, then we actually just leave a drain for this patient. There was a study in Cape Town that actually wrote about delayed presentations of stab hearts, where you can actually vigorously wash out the pericardium, make sure there's no fresh blood coming out. And if there's no fresh blood coming out, you can actually just leave a drain and then admit this patient in an ICU and high care environment and observe them, because they actually might be able not to progress. The biggest thing of chest trauma, stab hearts is different, but chest trauma is the incision you're going to make. Because if you make the wrong incision, your life is going to be quite terrible after that. So you need to know what incision to make. So this is the incision we make for anterior lateral thoracotomy. You try not to go too medial because you've got your internal mammary arteries there, and you try to follow the rib space that you're going to go to. And this is often done for unstable patients in the emergency room because it's the quickest access we can actually get. So when you open it up, you can see there's blood in the pericardium, and you have to open the pericardium. The one thing you must be careful of is the phrenic nerve that goes actually on the side of the pericardium. So you have to go at least 2 centimeters anterior to the phrenic nerve, and then you can actually release the tamponade. The problem for anterolateral thoracotomy, the advantage is quick access. Problems is that limited access. So if they got a right atrium injury, you're never going to get it from this side, and you're going to have to extend it to the other side. Probably the best incision, this is Prof. Plani, one of the previous head at Chris Barrett Hospital. One of the best accesses to do stab parts is a median sternotomy, who actually got this problems also, so it takes time to get access. The nice thing of it is you can access it into the neck if there's like major vessels going into the neck, but it gives you good access to the heart. If it's a left ventricle stab, you have to really, really carefully actually lift that heart up, because once you lift the heart, you do basically decrease the IVC and SVC return, and the patient will arrest immediately. So what you do is you prone the patient. We put basically swaps and wait a bit, swaps and wait a bit until we actually can get to the posterior part of the heart. But that's just the best access for actually stab hearts. This is opening the chest. You can see there open the sternum, and then they put the finisher and they get access to the heart. Whenever you get to the heart at that stage, you'll find that pericardium is so tight that you can't even cut it with scissors. So you often use the blade, and when you cut it with the blade, the first thing is that you actually have a heart attack yourself, because you wonder if you cut through the heart or it actually was just a tamponade release, because you just find blood pouring through the incision you've made. But then you then get rid of all the blood in the pericardium and then try to identify the possible areas of bleeding. So this is a clamshell. So you do a left and right anterolateral thoracotomies, and then you cross and open the chest. You can see there's a massive opening. Today, when we're going to do thoracotomy, we're going to do a clamshell, because it gives you best access and best view that you actually can see whatever you need to do. So when you open a heart and it's a right atrium injury and you do a left anterolateral thoracotomy, you're going to actually have to extend it to a clamshell to actually get access to the right atrium from it. It's an incision with a massive morbidity associated with it, but transmediastinal gunshot wounds, it probably gives you the best access to actually have a look and see what's happening with the heart. So this is classically how the injury look in the heart. So you get a stab wound in the heart. Often when you get there, because of the tamponade, they're not bleeding actively, but the moment you start filling with them, they start bleeding. Then you have to put your stitches in. So as I said, we don't have bypass machines at Baragwanath Hospital, so we have to do it in a beating heart. So you get a heart beating at 160 per minute, and you just see blood squirting everywhere. So you need to be very big needle, big stitch, and try to grab and try not to tear the pericardium. We don't routinely use pledget for these patients. We only use it for the elderly and massively dilated heart. And then here you can see it's a coronary running down there also, which you always must be aware of. So when you do emergent thoracotomy, you've got a big wound in the heart and you don't have anything at that stage to control the bleeding, what we do is we insert a Foley catheter into the heart. You inflate the Foleys, and then you pull it tight, and then you put a clamp onto it. So the clamp is to pull it tight and keep it in position, so to allow the balloon to actually tamponade the bleeding, and also to avoid it from bleeding out the other end of the Foley catheter. So then you can buy your time to get the patient into theatre where you can do a definitive procedure on these patients. The other option that you can use if you don't have Foleys, you can use the skin staples, and you can just staple the heart and then take them to theatre and then actually do a definitive procedure. Here's when you have a right atrium injury. When you get a right atrium injury, you can actually use the Satinsky clamp and then control the injury from the right atrium completely. The thing that you must make sure when you do it, you can see that's your SVC coming in there. You clamp it on the side and try not to cut down all venous return, because if you do, the heart's going to arrest. One important thing is whenever you do cardiac surgery, warm water, like very warm water, because that actually, you pour it on the heart, it stabilizes the heart, and you must have internal paddles ready and the internal defibrillator ready in theatre also. We actually lost last week a patient in OD where there was none of the internal paddles were compatible with the machine that was available. So you must be sure that you are well prepared for these patients. Then the tricky one is when the patient's got a stab that's next to the coronary artery, because you can't just stitch it, because you're going to occlude the coronary artery and cause actually them to have a myocardial infarction. So what you have to do is you have to do a mattress stitch. So we go underneath the laceration, underneath the coronary, and then you come back underneath the coronary, underneath the laceration, and then you tie it to this side to actually prevent you from cutting down the coronaries. So those are the ones that we often do. And then when we finish the operation, the pericardium, we actually do close 2/3 of the pericardium and leave 1/3 open. And the reason for leaving the 1/3 open is that we actually want the blood to drain if it's continue bleeding. And the reason for closing the pericardium is that you don't want the heart to stuck to the anterior chest wall. So the next time you open up the sternum, you're going to cut straight into the heart and the patient will die. So we often close the pericardium, 2/3 of the pericardium. I think that's all I've got for you. I hope it was enough and comprehensive enough.
Thanks very much, Rian. Certainly bringing visuals and reality of what can happen to the fore in a very real way. And I'm sure during the Q&A time, we can chat a bit more, particularly about things like myocardial contusions and so on, and some really wonderful tips and tricks for people out there who may not have immediate access, the Foley's catheters, the skin staples, how to address the issues if a coronary artery is around, and some of the very simple issues, you know, from a clinical perspective that are useful. So thank you very, very much, and look forward to further engagement as we move into the more latter portions of the webinar. I'm now going to ask Marissa to pick up the reins again, and she's going to step in for Prof. MOENG and address the issues with respect to an approach to neck trauma. Marissa, thank you once again very, very much for your input, expertise, and for sharing some really valuable and important lessons for everyone.
Thank you very much, Professor Mo. So going to look briefly at penetrating neck injuries specifically, because these are the ones that are quite challenging. Fortunately, significant blunt injuries that are lethal are very few and far between. So just what is defined as a penetrating neck injury? So here you can see a cut through the neck. So the platysma is the outermost muscle layer, quite a thin and flimsy muscle. And any injury that violates the platysma is then defined as a penetrating neck injury. Anything superficial to this can just be managed as a normal skin incision and closed. So of these, about 15 to 20% require surgical intervention, 3 to 10% overall mortality, the most common being exsanguination due to injury of the major vascular structures that you can see over here, and especially in your lower part of the neck, so the area that's behind the clavicles, that's quite a difficult area to reach surgically, so that's one of the areas that gives us the most challenges. So just to go through the zones of the neck. So these zones in the past were quite useful because they determined the management approach. So zone 1 is from the sternal notch and the clavicles up to the level of the cricoid cartilage. Zone 2 makes up the majority of the neck, that's from the cricoid cartilage up to the angle of the mandible, and zone 3 being from the angle of the mandible to the base of the skull. The reason why this was quite important in the past is that Zone 1 and Zone 3 was particularly difficult to access surgically. So these patients were generally subject to investigations. And because in the past investigations in this area were quite invasive, it was avoided as far as possible, and Zone 2 was regularly explored. With the advent of our multi-detector CT scans, we actually now image all of these patients provided that they are stable. So the zones are no longer that important because hopefully you will have a preoperative scan and you will know how to surgically access should the patient require surgery. What you'll find in these patients really depends on what structure is injured, and just bear in mind that, and if you think back on that initial anatomical sketch I showed, there's quite a density of structures in the neck. So just bear in mind that more than one structure can be injured. So as you start with any trauma, you need to do a primary survey looking for airway compromise, breathing compromise, and circulatory issues. Your single most important thing in managing these patients is to manage the airway appropriately. And some signs that you need to look for that suggest the urgent need to secure the airway is any large hematoma in the neck, patients that have hemoptysis, patients with distorted neck anatomy, patients who present with stridor, patients who have difficulty swallowing secretions, patients with very hoarse voices, or patients that are bleeding profusely from their mouths. And generally, fortunately, in the majority of cases, we can manage to control the airway through normal endotracheal intubation through the mouth. But unfortunately, in some cases, you do need to resort to a surgical airway. Please always have your difficult airway adjuncts ready so that you are ready for a difficult airway, and have your surgical airway kit next to you if you fail with a conventional airway, so that you can move to a surgical airway. And we will be discussing surgical airways in our practical sessions. You need to avoid giving muscle relaxants in these patients if you're going to intubate them. The reason for this being that once you relax all the muscles, then whatever muscle was holding, whatever muscular structures were holding the airway open will then collapse. And then these patients will then completely decompensate. If you need to give something because of trismus or anything like that, please give scoline, just because it's got a very short duration of action. And these patients will generally start breathing within about a minute, so that you at least don't have the patient collapsing. Awake surgical airway might be the best option, especially if there's quite a lot of distorted anatomy. Please don't force these patients to lie down if they're comfortable sitting. The best option is to let them suction their own mouth while sitting upright while you prepare everything. Please don't do any blind nasotracheal intubation, because that can disturb clots. And if the trachea is open, like in this image on the right-hand side, if you can actually visualize the trachea or the larynx, you can intubate directly through these lacerated structures as a maneuver to buy time. But please place stay sutures on it, because if you intubate a trachea that's partially severed with your intubation attempt, you might completely sever the trachea and it will retract into the chest. And before you can do anything to salvage that patient, the patient will die of hypoxia. Just bear in mind that any injury in the chest can also penetrate the apex of the lungs, so please look for pneumothoraces and manage them appropriately. These patients also often present with quite significant bleeding, so management of bleeding is another very important thing. Direct pressure to bleeding wounds is always going to be your first prize. Please don't explore these wounds in the ED, because if you make it bleed more, then there's going to be no coming back from that. Something that is illustrated on the image on the right, that is actually something that was initially described at Baragwanath, is the Foley's catheter tamponade. So what you can do is, through the penetrating wound, insert a Foley's catheter and then inflate the balloon, preferably with water or saline, and that will then tamponade the bleeding. And most of the Foley's catheter balloons can tolerate up to about 30 mils of fluid. So you can continue inflating it until it tamponades successfully. You will, in some cases, need to just put a stay suture or a purse-string suture around the wound just to keep the Foley's in situ. And just remember that you need to either clamp or knot the Foley's. Otherwise, you're just creating a direct conduit for the blood that was in the neck to drain out through the Foley's catheter. And as with any other trauma patient, large bore lines, limit your crystalloids and early blood product resuscitation. Investigation can be done in any stable patients. Unstable patients need to go to theatre directly for surgical exploration. Multi-detector CTs are our investigation of choice, and any other imaging will depend on the structures that are at risk of injury. And just remember that clinical examination in itself is not really reliable. The reason why CTs are good is you can do a CT angiogram at the same time to exclude any vascular injuries. You can accurately define the trajectory of your penetrating injury. You can also evaluate surrounding structures for injury, and any large amount of free air or any free air away from the wound tract is highly suggestive of an aerodigestive tract injury that will need further investigation. Also, any trajectory that runs through the area of the aerodigestive tract does warrant further investigation. Other investigations, like I said, based on what you suspect, you can do direct laryngoscopy, bronchoscopy, esophagoscopy, color flow Doppler ultrasound, not really done after you have done a CT angiogram because it's not going to add much. Conventional angiography with digital subtraction sometimes done. And the reason for this is in some cases, your bullet fragments can cause a bit of scatter that makes interpretation of a CT angiogram difficult. But with the newer imaging software available, that really isn't that much of an issue anymore. Surgical approach, just remember that if you are going to foresee that you need to do vascular repairs, that you also need to prepare the thigh in case you need to harvest the saphenous vein. In the majority of the neck injuries, just because of time constraints and the fact that you cannot clamp the carotid for a prolonged period, we actually use synthetic grafts. Generally, the neck incision is an oblique incision along the anterior border of the sternocleidomastoid, which can then be either inferiorly or superiorly extended. And if you need to do a bilateral neck exploration, you can do a horizontal collar incision. Like I said, we often use interposition grafts for our vascular injuries, and there's an example of that on the right-hand side of the screen. A single jugular vein can be ligated, but if there are bilateral internal jugular vein injuries, you do need to repair at least one. Shunting is a very good temporizing measure in your unstable patient. So that's basically any piece of plastic tubing that you can use to connect the two ends of the vessel. Very useful in unstable patients. You don't really need a lot of expertise or equipment. And they can stay in situ for up to 48 hours very safely. What we generally use as our conduits are nasogastric tubes, or if you have some of the high-capacity IV line tubing, that can also be used. And this can buy you time to refer the patient to a center that can go and do a formal vascular repair. Thank you. That's just a brief summary of neck injuries and the most common things we see.
Perfect. Thank you so very much, Marissa. And again, some really pragmatic, practical information, for example, the shunting elements for people who may be in difficult scenarios, and also very useful to know what to use. Nasogastric tube, or IV line tubing that can tolerate, larger sort of pressures. Very pragmatic, very practical. I think what we're going to do, Martin, I know that there are some questions that have come through. Perhaps it may be prudent at this point in time for the surgeons to move over to the skills laboratory. We'll hold over the questions. When they come back, we can kick off, with some of the questions that have come through. Whilst, in fact, the surgeons are making their way to the skills lab, what things stood out for you just from a pragmatic, practical perspective that was shared. I mean, and there were so many that stood out for me, where many of us may not necessarily be in the context of being trauma-trained surgeons in a critical care sense, but where we may have to deal with these entities, and where a degree of pragmatism can definitively go a long way to, in fact, saving lives. And I must say, looking back at this and being in a scenario, I work very closely with these surgeons that are on the webinar today, and I always take out something new every time that may have practical implication in terms of saving lives. What stood out for you as someone who has had extensive experience, who is on the road, in the air, every single day? What elements are real important issues to take out for the intensive care specialist or healthcare worker who may have to deal with these elements?
Thank you very much, Mervyn. So really also big thanks to all the speakers. I was really impressed by their vast experience and pragmatic approach. So you really notice that they're speaking from their everyday practice. And I definitely learned a lot. So from as you said, from every talk, and I took some notes just, for example, what I really loved with Marisa, when she spoke about tension pneumothorax and showed the X-ray picture, that this is a clinical diagnosis, and indeed it is. And what I think she brilliantly just enumerated on the clinical pictures. And when I think of those patients with tension pneumothorax, I usually see, or I saw, then I always remember all of them being extremely tachycardic and also having massive congestion of the head and the neck and the upper part of the chest. So this is always what I also come to teach for a clinical sign of tension pneumothorax. And another, I think, extremely important message Marisa gave, that needle decompression through the lateral aspect of the chest is a new approach. And I think one important point to note here is that needle decompression is an effective but only transient maneuver, something like a pressure valve to get the air out that makes the tension, but it's not a definitive treatment and requires intercostal chest tube insertion, as Marisa so excellently showed. And I also noted down that epidural catheters are just a wonderful way, especially in the awake patient who requires some non-invasive support, to provide excellent analgesia. And I remember from my experiences, interestingly, in Mongolia, they started to put in paravertebral catheters. And especially if there is unilateral chest injury, a paravertebral catheter may also be similarly effective. And I was very impressed by Rian's talk about cardiac trauma. And I think I have seen cases of blunt cardiac injury. I remember cases in London when working for the London Air Ambulance, in settings where penetrating trauma is much less common. I think cardiac injuries are rather quite rare incidents. When Marisa gave her second talk about neck injuries, I think I learned the most, because these are the most challenging injuries. And so I really liked her suggestion from a resuscitation point of view, not to wait too long with airway control or getting control of the airway. And I think it is something that one always tends to, if the patient is not right before surgery, that we wait until it's getting really difficult. So I think early airway control is a big thing in neck trauma.
Great, Martin. I'm going to stop at this point in time, and we're going to go immediately to the skills laboratory. As you can see, human cadaver. and one of our two expert surgeons is ready to get going. And so let's move over to them immediately, and we'll continue thereafter. Thank you so much for those valuable and excellent insights.
I'll make up the next one. Okay, you'll tell us when you want to. Okay, thank you very much for joining us. What we're going to do now, we're just going to go through some of the practical issues relating to the neck. I'm going to start with a needle cricothyroidotomy. And what I do, I always have to feel for the anatomy. 2 fingers can feel the larynx, and then I feel the gap in between. And that is a space where I would like to go through the cricothyroid membrane and insert one of the smaller versions that we've always used before. So what you do when you felt it and you stabilize the larynx, I will then insert a 14 gauge needle. And in this case, as I go through anteriorly, I can feel it popping at the back. And in that way, I'm able to advance the tube. If I didn't know exactly where I was, then I can always do and put a saline. And if you can look very carefully, you can see that there is a lot of air that confirms my position, and it's giving me bubbling as I go through this area. When I'm happy with this and I didn't have the other set, then I can connect it through to the oxygen tubing, running it at about 6 liters. But please notice there's a hole on the side, and I think this can only help you in children. We would do something differently when we are in a surgical team. And the way that we would prefer to do it in a surgical team, instead of going through a needle cricothyroidotomy, we will again identify our position, feel exactly where our cricothyroid membrane is, and we will make an incision. For those that don't do surgery all the time, I would suggest that you make an incision that is moving forward so that you can confirm that you are still in the correct space before you make an incision through the cricothyroid membrane. When you do this incision, do not extend it to the posterior wall, and you should be able to turn your blade and exchange that blade for a forceps that will help you to dilate the pathway further. As you I said, and with the ET tube, we are able to inflate. We can be able to back our patient from this area onwards. Of us, what we will do is, instead of this system, we will a similar system as for tracheostomies or even the smaller version of cricothyroidotomies area. We will then make an incision, a small skin incision, as we've done before. We will then take a needle, and the set comes in with the needle and the guide. We will then expose and insert the needle into the space, as you can see in this case. And then after we've inserted it, advance it a little bit more cordially. That allows us to take the guide wire, and with the guide wire, you will need to free it a little bit. With a guide wire, you will then be able to insert the guide wire into this area. I prefer the way that I confirmed earlier on and make sure that I have bubbles unless I can see the tube going directly through, but it will allow me an opportunity to leave the guide wire in, use the red system to dilate first, followed by the white system. And again, look at what your unit has and what are the different systems that they have available for you. In this set, it is almost a gradual dilatation. And unlike the other system, this one also uses a metal dilator. And the metal dilator will allow us to go through, make sure that we dilate just the anterior wall and be comfortable that it is well dilated before we insert a smaller size of a tracheostomy, because you must remember this, we are doing it in a hurry. Before we insert a smaller size of a tracheostomy tube and gently push it in so that you are able to inflate the tube and you can be able to ventilate your patient and watch the chest rise. So from what we can do here, we have an option of a needle crike, which most of us would not like to use unless we are dealing with children, to a primitive version of a surgical crike, where you are using a small size of an ET tube that is not the same as big. And here we had a size 6 that you can see properly in front of you. And if that is also a system that you don't have available, you can use a small tracheostomy, again going through the cricothyroid membrane and not the proper way that you do a trachea. And this can save your patient from dying from hypoxia when you are able to at least secure the airway and you are able to oxygenate them in an appropriate manner, and you can connect them to a ventilator under those circumstances. Once all of that is done, then we would like to secure. And what we do with the securing is to take the nylon sutures and we will make sure that we secure as much as possible from both ends. And in this case, we are able to make sure that we do not lose this functional airway in the middle of a patient that has forced us to insert it in a hurry, otherwise we will miss him. So recap, the cricothyroid membrane is a reliable area. Stabilize the larynx. Then confirm that your needle is in a good position unless you are doing a semi-open technique. Make your incision through the area of the cricothyroid membrane. And if you have a smaller trachea set, that might be a better one to insert. If you don't have it, use a small size AT tube and you will be able to save your patient, secure the tube, and voila, your patient can be ventilated and oxygenated moving forward. Thank you very much for your attention. Sorry, I need
Martin, so there we have a demonstration, and unfortunately we did have some connectivity issues, life-saving potential procedures, looking at cricothyroidotomies, fairly easily performed tracheostomies where you cannot intubate a patient from above, where the airway may not be accessible from above. Any pertinent points that you would like to re-emphasize there? I think Prof. MOENG summed up at the end the different options, but all of these things can be life-saving and actually performed by anyone, including in the intensive care setting. Just to go back to in fact, last week's webinar where we chatted about COVID-19, there were a couple of airways that we, in fact, had to access via some of these routes as an emergency, where it was impossible to intubate the patients. But in a trauma setting, this may be absolutely imperative. Your thoughts, insights?
I was very impressed about the setup. So that was really great. Thank you for everyone. So my experience with cricothyroidotomy, which is clearly limited, but I have two things that stick in my experience. The first thing is usually you wait too long. So in all the cases I have attended where a cric was necessary, the patient was either in a peri-arrest or already in an arrest situation, meaning that if you think about doing a cric or a front of neck access, as we call it now, then you should do it and go straight for it. I remember that in all cases, the needle approach and the guide wire failed in the emergency setting, because hematoma shifting of the trachea made it very difficult in both cases I can remember. So from that on, the scalpel cricothyroidotomy was always my first approach. So, but I think overall it's such a rare procedure that on the one hand it needs to be trained, and on the other hand, in the situation, you must not delay it when front of neck access is in your mind. And then I think the technique, people are most skilled with should be used. But I believe that the scalpel cricothyroidotomy, especially in the trauma acute setting, is the one to go for.
I think it's extremely useful. Obviously, in settings such as ours, we see this literally on a daily basis. We would expect all of our intensive care trainees to be fully au fait with all of these procedures. And I think we will rerun this element together with the pre-recording that is available, and people can in fact run through this and learn these procedures in between 5 and 15 minutes and feel comfortable to actually perform them. Prof. MOENG is a technical wizard, and I think has really refined the ways that one needs to address this. So we have various options that can be life-saving. Needle, as was mentioned, guide wire associated, and then scalpel mediated. And I think one of the big issues is just to choose a smaller size tube, a size 6 tube initially. And so for all those watching and those who hopefully will down the line, this is really a lesson in terms of how lives can be saved. You need to spend 5 to 15 minutes and you will feel comfortable in the context of things. So I wonder if we are ready to go back to the skills lab, and whether our audiovisual team can indicate to us whether we are ready to move forward with the next procedure.
I think we are ready, but just one comment came in from the UK where the scalpel boogie technique is taught, and that's a technique I've used as well, and this is also clearly highly effective. So I think the comment is absolutely valuable. Thank you.
Agree.
There's just the message coming that we have no video yet. Maybe, Mervyn, what are your thoughts or your experience when a cricothyroidotomy is done? When is the point? I mean, many of those patients anyway have to rush to the theater for bleeding problems. And there usually the cric is transformed into a tracheostomy. But if there's no need for immediate hemorrhage control surgery, when would you change over to a tracheostomy?
If it becomes overt that you're not going to be able to intubate this patient, even with adjunctive accesses available to one, or if because there is significant distortion. So very often in our setting, which as may have been shared, we rarely get to see an inordinate amount of trauma. If it is overtly obvious that we may compromise the patient further by trying to go more conventionally with airway entities, we will certainly go immediately for a cricothyroidotomy, whatever people feel most comfortable with. Very often, as mentioned, the scalpel route today is the easiest. I think the point that you made is don't wait. You don't want to be sitting with a patient who may be compromised hemodynamically, and now whom you're sitting with a major hypoxemic related issue as well. So address that entity. And I must say, if I look back over several years and you know, perhaps working closely with some of the people who are on this webinar, we don't really wait around too long. I must say it was one of the biggest lessons, I think, as I shared last week on the COVID-19 webinar. Airways are certainly very humbling. And I think the more you see and the more you're in this game, the more you recognize that sometimes you are going to be up against it, and these can be extremely life-saving procedures. I really liked the way that Steve MOENG shared a very simple way of performing a tracheostomy in an emergency scenario without really compromising patients, running into problems with vasculature. I think I really would advocate that people go back. Those who want to relook these elements, these videos are going to be made available. Go through them again and again and try them perhaps in your own skills laboratories. And there are various models that are easily done. We have one where we in fact can use very low access entities that are readily available. We use it again and again. And in fact, literally from intern level to elsewhere, we expect people to be comfortable, familiar, certainly with cricothyroidotomies, and as mentioned, the scalpel ones, they can be done literally within a very limited period of time, and they are absolutely life-saving. So I think airway management cannot be emphasized sufficiently. If we go back to some of the issues that were shared, and in fact in Marissa's last talk, I thought there were some pearls that came out. Don't use muscle relaxants in this sort of setting where you may have a compromised sort of airway. That can really, really be a huge problem. And we've certainly got away in temporizing scenarios where we've used jet insufflation. I don't know if you've used that as a temporizing measure. I think Steve MOENG's initial entity where there was a little bit of connectivity issue was exactly that, just utilizing a needle into the cricothyroid membrane, connecting oxygen tubing. Remember to make a hole over it or to obliterate the end and then open up, and you can oxygenate. And you will see the chest move at the time. And I can think of more than a handful of patients over the years that we've in fact salvaged whilst we were able to do something more definitive in those patients. So I don't think patients should ever succumb because we cannot get access to the airway. I think it's really, it's a travesty if that in fact happens. I remember, in fact, several months ago, a gentleman that we'd had who came in with a massive gunshot, self-inflicted injury, where he used a high caliber rifle under his neck and actually blew off much of the anterior aspect of his face. There was nothing identifiable, but everything below was accessible. And in fact, exactly as was demonstrated here, we were very quickly and adequately able to secure the airway with the scalpel cric converted into a tracheostomy, a small bore tube, size 6. And that patient, in fact, ultimately had a reconstruction of his face, and everything after many, many months went off favorably. So that was absolutely life-saving in this setting. I think we're ready to go, and I think this is Marissa who's going to take us through intercostal drain insertion. Please go ahead.
So I'm going to be demonstrating the insertion of an intercostal drain, and this can also double up as how you would do a finger thoracostomy in a patient with a tension pneumothorax. So firstly, you need to get your landmarks. So you'll feel for the sternal angle. Just below that would be the second intercostal space. Then you go down third, fourth, fifth, and then follow that laterally until you reach the mid-axillary line, and you go just anterior to that. Where you want to make your incision is on the superior portion of the inferior rib, just because you want to avoid injuring your neurovascular bundle. Then you'll make about a 2 centimeter long incision in line with the rib. Then you can use a blunt instrument to dissect through into the pleural cavity. Whether you're doing this for a hemothorax or a pneumothorax, you should feel a distinct give once you reach the pleural cavity. After doing this, The safest is to then insert your finger, do a finger sweep to make sure that there are no adhesions between the lung and the parietal pleura. And that's especially important in our country because we do have quite a high incidence of TB, like Dr. Pretorius has said. So then after you have ensured that you are in actual fact in the pleural cavity, you can insert a clamp onto your intercostal drain. That's going to be to help to guide it through this space. Insert your drain, ensuring that all of your holes are in the pleural cavity, and then angle it upwards and posteriorly. Please note that you also need to clamp the back of your tube because you don't want the patient to suck in air through this tube. And you also don't want to mess any possible hemothorax on your clothing. Then you can connect this to your intercostal drain bottle. In this case, we have the Sinapi drain that I spoke about earlier. So you can see it's quite a nice system. There's a needle-free port where you can put in some saline, 20 mils of saline to check for a leak. There's another needle-free port on this area where you will inject 1,000 units of heparin to use this for autotransfusion. If you want to autotransfuse, there's an attachment over here where you can attach your IV set. It's got a bulb that you can use to check if the pneumothorax has resolved, if this bulb stays collapsed after you squeezed it. And there's also an area where you can attach the patient to wall suction, and this is where you will adjust the pressure that you want the wall suction to be at if you need to clear any persistent pneumothoraces. After doing this, you will then need to secure your intercostal drain. We do this by inserting a mattress suture. Please make sure that you don't go through the intercostal drain when you insert your sutures, because if you do that, you will create an area of a persistent air leak. Then after doing this, you can insert a mosquito. If you've got a handy assistant, they can hold the mosquito in place for you. Then cut your needle off the suture because you don't want to stick yourself with a needle, especially in countries that do have a high rate of diseases that are bloodborne. Make a knot on your suture about halfway along. And then this piece of suture, before the knot, you will then wrap repeatedly around your intercostal drain. Once you reach the level of the knot, you can then put your suture, clamp your suture with the mosquito, pull it through the loop, and then you can tie the suture. Once you've secured this, you can then, with the remainder of your suture, make the so-called Roman sandal knot. And you can continue like this until your suture is finished. So just as a recap, the size of the intercostal drain tubes we use, we prefer to use something between a 32 and a 36, generally a bit bigger for hemothoraces so that they drain adequately. In terms of the size of your sutures, you want something like a nylon 1 or a nylon 0, just so that it's strong enough, because you don't want the suture to break and the intercostal drain to displace. Thank you.
Thanks very much to Marissa for sharing that with us. Again, wonderful lessons, nice practical, principled issues. I think a couple of them And Martin, maybe I can share a few thoughts that have come through as Marissa was doing that, and from lessons learned over the years, and perhaps your insights and commentary as you know they prepare for the next procedure. I think the first important issue is where one makes that incision, the superior portion of the inferior rib, hugely relevant, so you avoid any vascular injuries. And I think one of the important issues now is it doesn't really matter whether it's pneumo or hemo in terms of your drain, angle the drain upwards and posteriorly. That is a 2022 new issue, and was something that, in fact, I'd learned, you know, from a number of these wonderful colleagues. I think the Sinapi associated drainage bottles are really excellent. There are equivalent ones globally as well. And I think choosing the right size of the intercostal drain, so 32 to 36 from a pragmatic perspective with the bigger one for hemothoraces, really important. And then when you're securing the drain, that's really relevant because you often find displacement of the drain. Nylon is the suture material of choice, and choose size 1 or 0. So a couple of issues that really I think had come through, and I think Marissa took one through beautifully in the context of things. Any comments from your side, Martin?
Thank you, Mervyn. Thank you. It was really very nice and very educational. Also, thanks for your excellent comments, which I can just underline. My thoughts were that that what Marissa showed was the finger thoracostomy plus insertion of an intercostal drain. So with us, I think that's what we learned, especially from the pre-hospital setting in the UK. We came to use finger thoracostomy in the pre-hospital setting almost exclusively because so for the traumatic CPR situation, the traumatic cardiac arrest, that's we're trying to do the first bilateral finger thoracostomy, get a airway in and 100% oxygen, and then try to establish an IV access, and then just have a structured look at the patient and then decide whether we continue with the resuscitation attempts. And also, finger thoracostomy is a very, very effective method to release the chest in patients who have been intubated and mechanically ventilated. And from my experience, although theoretically you can find quite a lot of scenarios where insertion of a chest drain in the pre-hospital setting would be possible, but most of my cases were patients who had to be intubated. And then one last comment, which I absolutely loved, is that Marissa did not take any stylet, but she used the rubber drain with the forceps to insert the drain into the chest. There are so many different materials with steel stylets that are pointy at the end, and it can really puncture, especially structures like the heart or lungs, and can do more damage. So I would just really underline or highlight the need for inserting a rubber drain without any stylet, but doing it with the forceps.
Agree entirely. So yes, trocars are pretty much banned in our setting. I think they're potentially hazardous. Martin, thank you for those great insights. Let's move over back to the skills laboratory, where we'll have both Marissa and Rian, who are going to address issues of emergency room thoracotomy.
We're going to do a clamshell thoracotomy just for the purpose of teaching and better anatomy. Emergency room thoracotomies has also got a high morbidity and mortality associated with it, so you must know your indications for it quite well. And the one thing that also involves a lot of time emergency room thoracotomy is that people actually end up like pricking themselves with needles because of the excitement and the poor exposure and poor light. So the first thing you're going to need to do is this is the female, so we're going to go in from breast, so we're going to go in from mammary. You identify the rib, and when you do emergency thoracotomy, you must remember to follow the ribs. You can't just cut straight because then you're not going to be able to open appropriately. Dr. Yubert will assist me in opening the other side in the interest of time. So I can feel my rib spaces. I can feel where my intercostal space is, and I open my intercostal space. Once I've opened my intercostal space, that's when I actually start to use my scissors to help me to open the space better. The one thing is also when you go too far medially, you must remember your internal mammary arteries are there. So then I use my scissors. And the indications for this will be for emergent thoracotomies for hemodynamically unstable patients. We will do it for patients who are either tamponade, massive pneumothorax, or patients that's completely bled out, and we actually need to control the bleeding from the so either if someone's got a pelvic fracture or intra-abdominal fracture, to actually control it. This is a lip-shaped knife that we just use to open the sternum. Okay. Good. We insert our finiscietta. So now you can see the anatomy. You can see here's the lung, here's the heart. You can identify the heart there. It's got a little bit of adhesions onto the heart, but there you can see the heart. Pericardial sac. So the first thing I'm going to show you is how to do a cross-clamped aorta. Unfortunately, there's a bit of blood here, but what you can do is you identify. You get a retractor, and then you identify the tubular structure. Just pull up here. You can see there's a tubular structure there, and you open the pericardium, or the pleura, then open it there, and then you find that you actually got your aorta. It's a tubular structure. You can see there's the aorta there. I'm just trying to identify it a little bit more. So there you can see there's the aorta, the tubular structure that goes there. And what you want to do is you don't want to tear any of the intercostal arteries. And then what you do is you use a Satinsky clamp and you put it in on the aorta and you cross-clamp the aorta. Obviously, this is just a temporary measurement. What you try to do with that is perfuse the brain adequately and perfuse the heart, and then try to stop the bleeding from the chest and the pelvis and the abdomen. Okay. So then the next thing we discussed was so how to open the pericardium. So on this pericardium, you can see, as we just said in the discussion, there's the phrenic nerve there. So you don't want to cut the phrenic nerve. So if you do a sternotomy, you're going to often open it medially. If you do anterior lateral thoracotomy, you're going to open it anterior to the pericardium. So I'm going to anterior to the phrenic nerve. So I'm going to open it anterior to the phrenic nerve. And there you can see it's the heart coming out. What I'm going to do is I'm going to open the transverse also, so we can show you with the Satinsky how to control the right atrium also. So I'm going to open the pericardium completely. I'm just trying to remove the heart from the pericardium because it's still frozen. Okay, now you can see now the whole heart is actually exposed. So when you get a laceration, the first thing you have to do is you have to identify your coronary arteries. So you must try to avoid your coronary arteries. As you said in the discussion also, if there's a hole in the ventricle, so this will be a hole in the right ventricle because the left ventricle is actually posterior. What we do is we take the Foley's catheter, we insert the Foley's catheter into this defect, we then inflate And once the Foley is inflated, you put gentle pressure on it. You don't pull too hard, otherwise you're going to pull out the Foleys out of the heart. You can see there's the bulb there. And then what you can do is then you can put a clamp onto the Foleys and just keep it, put it snug onto it, keep it in position, and then you actually can take the patient to theatre to go and repair the defect in theatre. If there is a wound that's close to the coronaries, as we said, say if it's a wound is there, then the way we're going to repair it, because you don't want to take that coronaries, because the patient will immediately have a heart attack. So what you'll do is you will try to put a stitch underneath from the laceration, underneath to the coronary, and then come back and try to actually control with the coronary. So basically, whatever you must do is when you do a stab heart, you must have a big needle available, because the heart is beating and it's very difficult to find a needle while the heart's beating. So what you do is you put your stitch, go very deep, very far, and then you come back to the other side, basically you identify a coronary, and then you go back. And then you tie it. We also said in the discussion is that what you can sometimes use is skin staples as a temporary measure. Then in blunt trauma, we often see atrial injuries. The appendages of the atrium is often injured. So, sorry, let me just free it a little bit. But here you can see here's the atrium here. So if a part of the atrium is injured like this, what you can do is you just put a Satinsky over it without occluding the IVC return or SVC return. And then you can switch it, and you can see the SVC and IVC is down there in the back there, and then you can switch it also. And then the other thing is also, when you got holes, wounds in the back of the heart, you have to prime the heart. So what you have to do is you put swabs, you wait, put swabs, and you wait, and you put swabs, and you wait to lift the heart, because you can't just lift the heart. The moment you lift the heart is they will arrest. So you need to do it very slowly, and then put a stitch in the back, leave the heart to go back to its normal position, and then lift it slowly again, put a stitch, and then leave the heart to go back. And always have hot water ready, and always have internal paddles ready to actually defibrillate this patient also. And then from a lung point of view that we sometimes go to is when the lung doesn't expand properly. It could be either due to bleeding, or it could be a big fistula. So if there's a hole in the lung here, what we do is we don't just suture the two ends of the holes. We do what we call a tracheostomy. So you put a clamp here, you put another clamp on the other side, and then what you do is you open the tract completely, and once you open it up, you suture wherever the air leak or the bleeding is coming from, and then you can close the tract afterwards. But if you're going to just suture the two ends, the two holes closed, they will develop either air embolism or actually a hemoptysis also. I think that's most of the things in the chest I can show you. Thank you very much.
Thanks very much, Rian. That's really very insightful and extremely impressive as well. And I think for the viewers who are on today, they can really get an absolutely excellent idea of what working closely with the trauma surgeon, how relevant it is, and with many of the issues that are currently going on in various geographic areas of the world. Many of the entities that were shared today are absolutely life-saving. Very, very briefly, because time is quite tight at the present moment, we're going to allow the surgeons just to come back and join us. I think one of the things that I have seen salvage lives, and it is appears quite an invasive sort of issue in the appropriate setting with the appropriate people, and working closely in conjunction with the trauma surgeons and the intensivists is cross-clamping of the aorta. I've seen several lives actually being saved with people going home subsequently following that. So I think what we've really taken out of today, and I'm going to ask each of the trauma surgeons when they do have an opportunity to join us to give us one important take-home message. Whilst we're waiting for them, Martin, what are your 3 or 4 most important take-home messages from today's webinar, which I think is the first time that these procedures have been demonstrated in a human cadaver for the intensive care fraternity anywhere globally. So fairly unique, really important stuff. I thought the initial entree with the 3 overviews was really excellent. It was pragmatic advice that was absolutely practical, even for people who do not have access to the more invasive sort of issues that could save lives whilst you're transferring patients perhaps to a bigger center. And if you want to share perhaps just 3 or 4 of your own important messages that have come out of today's webinar.
Thank you, Mervyn. So just recapitulating again on the talks, I think what Marissa in her initial talk on chest trauma, I think so excellently outlined was that the liberal use of intercostal chest drains in patients with severe chest trauma, and that the need for emergency surgery is very low, only for a very, very selected group of patients. And then these surgical procedures should be done by people experienced in thoracic surgery. Regarding the talk of Rian on cardiac trauma, I think what I learned was that that in blunt trauma, atrial injury is one of the most common injuries, apart from myocardial contusion, which I think laboratory-wise is frequently seen in trauma, but I'm not sure about the clinical relevance of deviations of cardiac enzymes in those patients if they don't have rhythm disturbances or any contractility issues. And finally, I think from the talk or presentation on penetrating neck trauma, I learned a lot about emergency procedures to stop the bleed, specifically relating to the insertion of Foley catheters, but also just the importance of securing the airway early, and if not possible through the oral or nasal route, that we should go for a front of neck access before the patient is in a peri-arrest or arrest situation.
Brilliant, thank you. I'm going to ask our 3 trauma experts, and Prof. MOENG, thank you so much. I know you were caught up with important issues that will save lives down the line. From the entities, and you and I discussed over many, many weeks how we could go about putting this webinar together, what elements were relevant, what we should be sharing, and how this close association between trauma and intensive care medicine works. Could you give us your take-home message for a broad global audience as to a real pragmatic message to take out? And I'm going to ask the same of Marissa and the same of Rian. What issues in your mind are absolutely life-saving, and what are the pragmatic tricks at the end of this webinar that people must, in fact, endear themselves with and feel comfortable with and run forward with as a principled way?
Thank you very much, Prof. May, and to the audience. From my point of view, I think the simple message, number 1, is that trauma is a team effort. You work as a team. It's a collaboration between the front room team, the ICU critical care, the surgical team. And whenever you develop anything else, look at developing it from that perspective. It can always make you save more lives. Secondly, it's actually the simple steps that saves people's lives. It's identifying that airway that is in trouble and securing it, simply identifying that they are bleeding and getting them to theater. So I think and I hope that even in a confusing environment like neck trauma, as it was eloquently presented earlier on, we need to break it down into simple steps. Is my airway sorted out? Is bleeding managed?
because it gives us an opportunity to think better and to be able to move on with the rest of the care. And it's the simple things that can save a patient's life, irrespective of how complex they are. And then we can be able to buy on into more definitive work. So don't underestimate things like intercostal drains. Don't underestimate things like being able to identify a patient that needs emergency room thoracotomy. And I'm hoping that all of these will add value in our endeavor to try and minimize mortalities and improve patients' life when they've exposed significant trauma. Thank you very much.
Steve, just whilst we have you, just in the entity, whilst you were going through your very eloquent demonstration of securing the airway, would you like to just recap some elements? There were a few breakages in transmission, just important take-home messages for people out there that are going to save lives.
Again, start simple. Most of the patients can have their airway secured in a normal way. If that fails and you can't do rescue maneuvers, you've got a patient that is not suitable for simple intubation, then we start thinking of surgical airways. Make sure in that appropriate group of difficult cases that you at least stabilize the larynx, work through the cricothyroid membrane, and that is a safe anatomy in the middle of mayhem of a patient that is about to have complications of hypoxemia. And again, that cricothyroid membrane, use the simplest way to enter into it. And for most of us, it will be the surgical airway. If you don't have the advanced methods and the advanced technique, a simple small ET tube can help you. A simple modification of a small tracheostomy set can help you, as we had demonstrated. Don't forget to secure it, because the last thing that you need is to lose an airway that you have struggled to insert from the beginning. Thank you.
Brilliant advice, sage advice, very wise advice. Marissa, you've been awesome during this webinar. What are your take-home messages for the practical, pragmatic intensivist based on the entities covered, dominantly chest trauma and neck trauma? Take-home messages.
Thank you, Prof. As Prof. MOENG has said, always just focus on the basics. Make sure that the airway is controlled, the bleeding has stopped, and bear in mind that the greatest thing that you can have is practice, and don't forget to do things like simulations in order so that your entire team is comfortable with it. And once something starts feeling routine, then the emotions aren't so high. And once with trauma, the most important thing really is to stay calm. Follow your basics, follow your steps. So the more often you repeat those steps of going airway, breathing, circulation, and manage them as they crop up, the more natural it will start to feel, and the outcomes will speak for themselves.
Thank you very much for your outstanding contribution. And finally, Rian, perhaps some take-home messages from your perspective relating to cardiac injuries.
Thanks, Prof. So first I would say is that I agree with what all the previous speakers said about stick to the basics. And I think ATLS is still a big part of the backbone of teaching people who are not trauma surgeons how to deal with it. I think cardiac injuries, think of it, because I think we often ignore it. Obviously, in the country where we're from, where we see a lot of penetrating trauma, we always think about it. Countries who see less penetrating trauma, then you also, you're not so aware of it all the time. I think that whenever you do any of these procedures, there should be a team leader. And the team leader should be the one who make all the calls. And the team leader should always stay calm. If you stay calm, as I said, with emergent thoracotomies, there's a high incidence of needle pricks and people getting injured because of the excitement, poor light, and everybody trying to do it simultaneously. And as long as you stay calm, to solve the problem is actually is not that difficult. And I must be honest that a lot of our stair parts do a lot better than people expect. And it sounds dramatic, it looks dramatic, and everybody wants to see it when it's there. But if they're stable and they're not getting arrhythmias, they actually do quite well. So I think that if you control it as quick as possible and use simple techniques to control it until definitive care, the patient should be fine.
Excellent advice. Once again, Martin, your final comment.
Well, I think I can't really say anything more to what has already been said. I would just like to thank everyone. I want to thank the really great speakers and the nice presentation. And I especially loved the comment that Professor MOENG said that trauma is teamwork. I think this is a very, very important aspect, no matter where we are and where we practice. Thank you so much.
Martin, again, very, very sage issues, as is one of the logos of this society. Together we are intensive care. And that's a very important issue, and that's trauma and it's intensive care. We all need to work in a collaborative fashion, in that calm, cool, collected fashion that Rian has shared with us. So I'd like to just thank everyone involved in this unique and novel webinar. As mentioned, it's the first time, as far as we're aware, that any such webinar has been hosted in the ICU fraternity anywhere in the world. And I want to just remind people to join us next week on the 19th of September, same time, for a second webinar in this trauma series. And then finally, my personal and very gracious and humble thank you to absolutely everyone involved today, to all those who joined us. And I wish you a very pleasant rest of morning, day, and evening. And additionally, as someone who is involved in the global group, a very happy World Sepsis Day. And watch this space for more exciting educational, meaningful entities from ESICM and the Global Intensive Care Group in both of these domains. So with that, I'm going to close. And thank you once again, very graciously, very humbly, and look forward to seeing you all again next week. Thank you so much. Bye-bye.
Thank you.